Welcome to Coming Together for Sexual Health. I'm Tammy Kramer, and I'm thrilled to talk with you about the world we are creating by coming together for sexual health. And yes, the pun is intended. My background in thinking holistically about health as a facilitator and a doula helps me talk with our guests about celebrating pleasure, combating stigma, and making sexual health care both more accessible and more inclusive of the communities we serve. We're powered by nationally recognized experts in sexual health at the University of California, San Francisco, and the California Prevention Training Center. All views expressed are those of the person speaking and not of the CAPTC or their employer. Subscribe to get our latest episodes, share with your friends, and leave us a 5-star review to help more people find us. Thank you for coming together for sexual health. In Season 4, we did a mini-series on family planning and reproductive justice. In this compilation episode, we've put together the first 10 minutes of each of those conversations. Go back and listen to the one that speaks to you. Welcome to Coming Together for Sexual Health, Professor Diana Green-Foster. So glad to have you here today.
Thank you so much, Tammy, for having me.
Today's episode is going to be one of 3 in our series on reproductive justice and family planning. Diana Green-Foster, PhD, is a demographer and professor at the University of California, San Francisco. She led the United States Turnaway Study, a nationwide longitudinal prospective study of the health and well-being of women who seek abortion, including both women who do and do not receive the abortion. She is leading a study of the health, legal, and economic consequences of the end of Roe in the United States and a Turnaway study in Nepal. She is the author of over 120 scientific papers, as well as the 2020 book, The Turnaway Study, 10 Years, 1,000 Women, and the Consequences of Having or Being Denied an Abortion. So as we jump in here, I just want to hear, first of all, if you could describe your body of work and what drives you to do the work that you do.
I have been working for over 25 years to look at how access to contraception and abortion affects people's lives. And for a while, that meant things like estimating the effectiveness of family planning programs or showing that if you give a person a whole year's supply of birth control pills, they're less likely to become pregnant. And that research led to law change in about 20 states. So that had a big impact. Certainly what I'm most famous for is the Turnaway Study, which looks at the consequences for people who want an abortion. What happens if they can get that abortion? What happens if they can't? And at the time we started that study, really we were trying to address the question that was an open question, which is, does abortion hurt women? Because the Supreme Court and many state governments had put restrictions on abortion with the idea that getting an abortion might cause people mental health harm. And I don't know how sincerely they believed that, but there certainly wasn't great data to support it. And what's important is to compare people who get an abortion to people who want one and cannot get one. Because if you're going to restrict access to abortion, they won't magically become unpregnant. They'll instead carry a pregnancy to term. When we started the studies, the main conversation was mental health of abortion versus no abortion. But unfortunately, since then, abortion restrictions have become much stronger. In fact, there are 13 states with bans. And so really the experience now of the group that was unable to get an abortion is the most interesting group, because that's what's going to happen to anyone who isn't able to circumvent their state's laws.
I'm really struck as you're describing your body of work, how you have found ways to do research that really has a direct impact on practice and legislation. I'd love to hear a little bit about what that process is like to select those projects and how you position your work.
I don't think I went into this trying to do the most policy relevant work. Every time I started something new, it was because somebody said something that sparked an idea. I was talking to the physician Bimla Schwartz, and she mentioned that people can remove their own IUDs. And it was news to me, someone who's used IUDs, that was possible. And I realized that IUDs can be a coercive method of family planning if people don't know they can remove it. And so I did a series of studies to look at whether people can remove it and how it changes their attitudes about the method. If anything underpins all of my work, it's a feminist desire for people to have control over their own family planning, their own childbearing.
I recently sat in on a training for providers around placing IUDs, and the trainer mentioned the ability for folks to remove their own and how she would generally ask folks and leave the strings a bit longer to make that easier for their patients. Simultaneously, she noted it's not, so to speak, approved consistent practice according to the body that she was accountable to. So just seeing how much less coercive it could be to have folks really know that they can control that removal.
What a wonderful clinician you were speaking with.
Yeah. I want to show you my shirt. It says, "Everybody knows I had an abortion." This work is, very both professionally meaningful to me and also very personally meaningful to me. And after I had my abortion, about a year and a half later, I was seeing a provider and I shared a bit about where my mental health was at that point. And this provider repeatedly asked me if the hardship that I was experiencing was due to my abortion, even though I shared that timelines did not match up with that interpretation. I really feel the importance of this work of debunking these kind of broadly accepted ideas that abortion has to be traumatic, abortion has to be something that causes pain, where of course there's many different experiences of what that's like. For me, abortion was freedom and choice about how I live my life. So I just wanted to bring that personal grounding into this conversation.
Yeah, you've encapsulated a lot of the debate right there. If we find higher depression among people who seek abortions, is it the abortion that caused it? Or might there be some other explanation? And you're right that people have a range of emotional responses, and yet we find no evidence that abortion causes mental health problems. You can feel sad, and that doesn't mean that you're depressed. And it also doesn't mean that you feel like the abortion was the wrong decision. And I'm not saying everyone feels sad. There's a big range of emotional responses.
Right. We can feel something is hard and we can be grateful for it and being able to hold that complexity that this experience can really have. So, what would you like providers to understand about the Turnaway study? And if you can give us a little bit more information about some of the kind of the key findings there and how that might impact care.
So I'm going to direct this to the provider who suggested that the abortion was causing you mental health harm. What we find is that abortion is not associated with mental health problems. In fact, women who are denied abortions do worse than women who receive them. We see higher anxiety, lower self esteem for people who cannot get the abortion they want. And that's in the short run. In the long run, we see that, in fact, the mental health of people who receive and who are denied abortions are similar. But they're not similar in other ways. There are huge differences in physical health. So we see that women who are denied the abortion, carry the pregnancy to term, give birth, have much higher, much more serious complications from the end of pregnancy than people who get an abortion, even people who get an abortion in the second trimester. And that's consistent with the medical literature, and it's so grossly underestimated, underappreciated by the vast majority of us who take for granted childbirth and don't realize that it is a entire physiological stress test and every organ system is affected and anything that can go wrong will go wrong sometime. And in fact, 2 women in our study died of childbirth related causes. So for some people, they have an uncomplicated pregnancy, and for some people, they die from complications of childbirth. And to act like that this should be something that people can't opt into, that it should be forced upon them, seems just clearly wrong. In addition to the end of pregnancy, we see worse physical health that lasts for years among the people who give birth compared to the people who receive it. So we need a much greater appreciation for the risks of childbearing and the sacrifice that people make when they want to give birth. So physical health is different, but then there's a lot of other outcomes that we studied that differ for the people who receive an abortion and who are denied them. And I'm sure that your listeners won't be surprised that having a child, raising a child, causes a slew of changes to one's life trajectory. So we see greater poverty, greater chance that the household is living without enough resources to pay for basic living needs, less chance that the person is working a full-time job, We see greater debt. We see less likely to set aspirational plans, less likely to be able to care for existing children, less likely to have intended children in the future, less likely to have a high quality romantic relationship in the future. And all of those negative outcomes are for the people who carry the pregnancy to term, not the people who have the abortion. The other striking thing about all of these findings is that when people are making the decision about what to do with an unexpected pregnancy and they decide on abortion, all the reasons they give us are exactly those outcomes that we see for people who are denied. So when people are making this decision, they're making a careful decision. They totally understand what the consequences are going to be if they're unable to get that abortion. And it's what motivates them to get that abortion. The final conclusion is that we can trust people's decision making on abortion. And when someone else makes that decision, for example, our government, people's outcomes will be worse. That's not just the pregnant person, but their kids, their chance at achieving other life goals, including having wanted kids later. That's why abortion is in the news all the time, because people know at their core level that this basic ability to control your childbearing, to decide who to have kids with and when and whether, are all so fundamental to enjoyment of life and living life on your own terms.
Yeah, I really appreciate understanding that kind of congruence between the considerations that folks have in the decision making and the outcomes that people have who are forced to proceed with unwanted pregnancies or are denied abortion. I think that helps to demystify a bit and defog this very thick fog that I know I experienced when facing this decision myself, because there's so many layers of political debate that finding oneself among those things and being able to trust my own perspective was a lot more labor because of all of these kind of myths and stories about the impact of abortion. So seeing that congruence is really reassuring and affirming, like you said, that people can make choices for themselves.
Yeah, I think that people's decision making is clearly affected by stigma, about how stigmatized this topic is, and affected by support from other people. But it's clear that when someone's made the decision, that they are very likely right about the outcomes of their life and should be trusted to make their own decisions.
Welcome to the second episode of the three-part family planning and reproductive justice series here on Coming Together for Sexual Health. Today, we're joined by Mariana Horn and Dr. Jen Carlin, and we're going to be talking about the edges of conversations we have about contraception, things that don't often get talked about, types of birth control options, and side effects. So I'm going to start by introducing Mariana Horn. She's a health educator and outreach lead at UCSF New Generation Health Clinic. She has a strong commitment to addressing racial inequities and disparities in reproductive health care and has been a prominent advocate and educator for anyone in need of reproductive care, particularly monolingual Spanish-speaking communities. So welcome, Mariana.
Thank you so much.
And we also have Dr. Jennifer Carlin, MD, PhD. And Jen is a board-certified family physician and family planning specialist whose primary care practice is anchored in caring for patients in a way that encourages their empowerment and autonomy. She's trained as an anthropologist and historian of medicine, and her research aims to understand how social, political, and institutional structures affect people's experiences with diagnosis, treatment, and healthcare. Dr. Carlin is also committed to medical and resident education that aims to encourage physicians in training to approach their practices from an historical, trauma-informed, and self-reflexive perspective. Welcome, Jen.
Thanks so much. I'm so happy to be here.
I'm so glad to have both of you today, and especially to have the two of you in conversation. And I want to start us off by talking about what experiences you bring when it comes to supporting people in choosing and getting on birth control. Mariana, if you want to start.
I'm a health educator and the first point of contact with patients. I'm a certified family planning counselor, and also I'm a data reporter. So I educate people about the birth control methods that are available for them, and I share the information for them to make an informed decision.
Great, thanks. How about you, Jen?
Yeah, so I am a family doctor, which means that I take care of people from birth until death. And I have focused fellowship training in family planning. I really focus on sexual and reproductive health for my patients. And my background is in anthropology and history of medicine, and really thinking about how can the healthcare system meet people's needs in ways that are more empowering for them. And that has meant different things in different places across the world and throughout time. I really came from this from an experience earlier on in my life where my mom was pretty sick when I was young, mainly through high school. She had lupus and was constantly seeing doctors and was misdiagnosed for years and had physicians saying all sorts of different things to her, like, you're probably just too stressed. And that's the reason why you're feeling this way. Or it's because your daughter is going to college, or it's because you're a business owner. And we used to sit at home thinking, why are people saying these things to you? And I got really curious about the ways in which we think about patients and people were constructed. And later on, actually, my mom ended up passing away from inflammatory breast cancer. And she had missed her mammogram by about 6 months. And a doctor literally said to her, "Well, you missed your mammogram. Now we can't fit you in." She used to tell me that every time she would see him in the hallway of the hospital afterwards, she would want to turn around and run away. It was a really eye opening experience as a young kid. And so that's sort of the reason why I wanted to go get background training in anthropology and history of medicine, but also wanted to be able to be a practitioner to see if we could take those lessons and actually put them into action in the clinic setting.
Thank you for sharing that. I can understand how growing up and seeing that would must be so confusing to have that contrast and negotiate that.
I want to say that, Jen, thank you so much for sharing your story. It's very inspiring. My story is a little bit different. I come from a very Catholic family where none of the information was available to us, only what we learned at school and little that we learned from our parents, which was if you kiss somebody, you can get pregnant. I remember some of my friends went to their first OB appointment. And I was just very curious because it was not until like late in my late teens that I decided I don't care if my parents know that I went to an OB because I'm using their insurance, but I need to go just to ask questions. I had a professor that she was just talking to us about reproductive health, and she was an OB, and I just went to have an appointment with her. And I was just like, I just don't know anything. And she was like, you know what? Thank you for coming. So I remember that first appointment was kind of like 2 hours, just like talking. She was one of the first persons that said, is your body is your choice. And I'm like, oh, wow, I have a say in what happens with my body. That resonated with me so much. And she was like, there is a career like reproductive health and public health. And I'm from Mexico, so it was a long track to get here. And here I am advocating for reproductive justice, advocating for people that are monolingual Spanish speaking and they feel that they don't have a choice or a say in what happens with their bodies. They're surprised to hear that they can choose. And I just love being a health educator.
That's really powerful to move from the place of your own experience of not having access to information. And I want to ask both of you, what are your priorities and values when you're working with clients who are interested in getting on birth control? And can you share an example of a way that a conversation might play out about that?
First of all, I also wanted to mention that I was partly trained at New Generation. In most of healthcare, you have to go to the doctor between 8:30 and 5, and that's usually the time that lots of people are working or in school. And what is so empowering about the model of care at New Gen is that people can drop in later in the day and on weekends. The kind of space that creates when you allow people to have a conversation that is maybe intimate for them. For some people, talking about contraception is not intimate at all, right? Just allowing them to choose the time and place to do it sort of talks a little bit about my values. I try to be as open-ended as possible and learn what is someone looking for from the conversation. It might not be that someone is looking to start contraception right then, but they're looking to learn more about themselves and more about their body and the environment. And so offer additional options that people may not know about, but offer them in ways that doesn't feel coercive at all. So saying, would you like to hear more about this? So, for example, I have a patient that came to me. She was an older Latina woman in her 40s and was having a lot of heavy bleeding from fibroids. And she had had a lot of sexual trauma, also pregnancy loss. And a provider had told her previously that a way to deal with her heavy bleeding would be by putting in a progestin IUD. So putting in a Mirena. So she had come to me to place that Mirena because the provider who had told her that felt uncomfortable placing it with the fibroids that were in her uterus. And I could just tell that she was so scared of doing this, but felt that she had to because she felt like if she didn't place the IUD, she would continue to have heavy bleeding and suffering. This was really the only option that she had been offered. And so, at some point I said, you look scared. Can you tell me a little bit about that? And she started telling me about the pregnancy losses she had had and how she actually had had an IUD before and then had a miscarriage and was scared that that was what had caused the miscarriage and held all this guilt. And it was complicated with some sexual trauma she had had previously. And so I said, you do not need to do this. We can find another way to manage your heavy bleeding. And just the fact of being told, like, you don't have to do this right now, gave her the space to, like, actually think about other options. So then she left and came back, and we used an injectable contraception, Depo-Provera, to help manage her heavy bleeding. Even though I want to have conversations that feel comfortable with people, I'm a white provider. I am in my mid-40s. I am highly educated. So there's a lot of power dynamics that go into the conversations that I have. And I think it's really important to pick up cues and be slow and not just try to, okay, this person is scheduled for an IUD. We're going to place the IUD, like even if they look a little scared, and not actually open up that conversation because that conversation took 45 minutes in a 15-minute slot. But those are the conversations that are just so important to help people feel in control of their bodies, both within the clinical space and then when they go outside the clinical space, which is actually what's even more important to me because that's where they're spending most of their time. So I want them to take that feeling of autonomy of like, oh, this is my body. I get to make choices about it. I want everybody to walk around the world knowing that and feeling that and acting that when they're not in the clinical space.
Today's episode is the third in our series on family planning and reproductive health. The last two episodes focused on abortion and birth control options. Today, we're discussing family planning with transgender and gender-diverse people specifically, both for those who want to prevent pregnancy and for those who are looking to preserve their fertility or get pregnant. I'm joined by Miles Harris, FNP BC, he, him. Miles is a trans and non-binary identified family nurse practitioner and serves as the founding director of Gender Affirming Care for the University of California at Davis Health. Miles is an assistant clinical professor at the UC Davis Betty Irene Moore School of Nursing. Miles's research focuses on sexual and reproductive health needs of transgender and gender non-binary people. He's an advocate for the integration of gender-affirming care with primary care and has trained healthcare students and providers across the U.S. I first met Miles during his presentation on family building and contraception for transgender and gender non-binary patients at the Trans Health Summit in San Francisco earlier this year, a biennial conference that I'd highly recommend if you're interested in serving this community. So welcome, Miles. I'm so glad to get to chat with you today.
I'm excited to be here. Thanks for having me.
So just to get us started, I'd love to hear from you a bit about your story. Can you tell me about yourself, your training, the work you do, and why you chose it?
I've been a family nurse practitioner since 2015 and a nurse since 2012. I didn't go to college for nursing initially. I went to Carleton College, which is a liberal arts school in the Midwest, where I studied biology and studio art and graduated in 2008, which was not a great moment of the economy to graduate into. I had done EMT training, and throughout college, I had worked at our college's gender and sexuality center and had done a lot of sexuality education as a part of that. And sort of around the same time, had met some nurse practitioners who I really loved and felt like they seemed to love their jobs too. And so that's kind of what led me down this road into nursing. And I did not intend, or at least in the beginning envision, sort of have a focus in gender affirming care or trans and non-binary health. I really feel like it sort of picked me, but it is something that I love to do, and I love to be able to do so much to advocate and support my community.
What a cool space to find yourself in. And it's just really impressive to see how much you've been able to lead in this area in terms of your current work. I'm wondering, now that you are involved in gender affirming care, now that it has chosen you, what are some highlights? Can you share any like aha moments or memories early on in this work that you were like, oh, this work, this is for me?
It's really a lot of sort of like individual visits, individual patients. What we as healthcare providers do for trans and non binary patients, it's so straightforward. It's not hard, right? The medications are generally not complex. It's easier than diabetes, right? Like it is most of the time pretty straightforward. And it's just about creating access. And so I really encourage anybody who's in a healthcare role to know that whether that's helping someone figure out how to navigate to whatever surgical option they're interested in or get started on hormones, or sort of like be the person that signs the piece of paper that lets somebody change their identification if you live in a state that requires that. Like it is often so easy as a healthcare provider to do the thing that someone needs that changes their life.
I think that's the first time I've ever heard gender affirming care be described as easier than diabetes. And I'm going to take that one with me.
Yes, I've gotten to be a part of that for hundreds of people. Every single one of those feels special. Getting to be a trans or non binary person providing healthcare for your own community is really special and magical.
The magic of being able to provide care to trans and non-binary folks as a trans and non-binary identified person yourself. Can you share any stories about a time where that felt particularly true for you, or you felt like especially connected with one of your patients?
There's someone who I have provided care to for a few years who also identifies as a trans and non binary person. That person sort of earlier transition really felt like they were just presented with like very binary transition options and pursued a lot of masculinizing options and surgical options because that was sort of the path they were shown. And if you are trans, this is what you do. And when we had established a relationship, I think really in us having conversations about like, there's no what are you supposed to do? This is like, what do you want for yourself? What do you want for your own body? And there is no right answer. And also, you can try something and it cannot fit, and then we can pivot, we can do something else. And so, over the course of the past few years, I have supported this person really in exploration of trying to figure out what fits best, both in terms of hormones, but also in terms of like name and gender presentation. And this person has told me that getting to see me as another trans and non binary person with a gender presentation that is not binary, you know, have a mustache and I'm wearing lipstick today, right? And I have a mustache and wear lipstick almost every day. For that person getting to figure out what fits what feels best for them, along with me, with another person who has spent a lot of time trying to figure out the world of options of ways to figure out what gender feels good. It's been a really beautiful journey with that person, and I've feel honored to get to have supported them through that, and I think they're in a place that they're pretty happy about. So it's really a joy. And I think maybe that's sort of like another point that I would like to make about providing gender affirming care is that it's sort of special in the way that maybe I'm going to try this example. It might get weird or it might not fit, but like, providing care to someone who is pregnant might be. This is not like a disease or a problem, right, that we are fixing. This is supporting someone through a journey, perhaps, and helping them do something in the way that feels best and most authentic to that person, and really like helping someone find their joy, find their gender euphoria, and being sort of like a witness and a part of that. It's really special. It's really an honor. And I think, because I do it every single day, it's perhaps something that sort of like loses a little bit of salience for me, honestly. But getting to sort of like really reflect on how special that is, this has been a nice opportunity to do that.
Yeah. Wow. That does sound really fulfilling to get to just witness people becoming and to support that process. Thanks for listening, and please follow and rate us wherever you get your podcasts to help more people find us. And hey, how about sharing this with a friend or a colleague you'd like to talk with about sexual health? Check out the show notes for the resources mentioned in this episode and the transcript of the show. Connect with us on Instagram at Coming Together Pod, on X at California PTC, and at comingtogetherpod.com. This podcast is produced by me, Tammy Kramer, with our editor and co-producer, Isaiah Ashburn. We're based at the University of California, San Francisco, and would like to acknowledge the Ramaytush Ohlone people, the traditional custodians of the land that UCSF sits upon. Thank you for coming together for sexual health.